I'm a vice president with Health Management Associates. We're a national healthcare consulting and research firm. And I'm here primarily because I actually have a long professional history of doing lots and lots of wonderful fun things with NCSL in various roles and jobs that I've had, but also because I do anything that Martha King tells me to do. So anyway, my role today is to facilitate this discussion. So I'll be kicking things off and asking some key questions to our panelists today, and they will answer, and then we'll make sure we get through the questions that we developed ahead of time by 4:30, so that you all have an opportunity to ask questions, and you'll see the microphones here in the middle of the room. So as you're hearing some of the responses to the questions that we prepared in advance, feel free to jot down additional questions or follow-ups that you may have. I'd like to introduce our panel very quickly, and then we'll jump right into the program. To my far left is Representative Dunnigan from Utah, who currently serves as the chair of the Business and Labor Committee. He's a member of the Political Subdivisions Committee and a member of Business Labor. He's Speaker Pro Tem and is on the Economic Development Appropriations Committee. Next to Representative Dunnigan is Emma Chacon, is the Assistant Division Director of the Utah Medicaid and Health Finance Office. In her role, she is responsible for implementation of health reform and cost containment efforts. And then next to Emma is Nathan Johnson, who is the Medicaid Policy Manager here in the state of Washington for the Washington Healthcare Authority. He coordinates policy research and planning that support program development and implementation of federal and state health policy. And then finally, we have Washington State Senator Randy Becker, who is chair of the Healthcare Committee and co-chair of Healthcare Oversight Joint Select Committee. She's been working in the medical field very long in her career, everything from a receptionist to an administrator of a surgical center. So we have a great panel lined up for you today, and I'm going to kick this off with just a couple of comments and then a question. So this question of Medicaid reform, I know when I was cabinet secretary over our state Medicaid agency in Colorado, I would often get the question, well, aren't we done yet? We've been reforming. I mean, when do we get to the end of this thing? And states have began reforms long before the Affordable Care Act. And the two states that we're featuring on this particular panel are actually very good examples of that, along with some of the other what I would consider pioneer states like Minnesota, Tennessee, Oregon, Vermont. And innovation came from both sides of the aisle and from both parties, and driven sometimes by executive branch, driven sometimes by legislative branch, but I would suggest that in states that have had success, they did that together, that the legislative and executive branches had to come together, and the parties certainly had to come together in order to really be successful. States have been using, you've heard of 1115 waivers. They're getting a lot of press right now because there's sort of an uptick of waivers and a preparation of waivers, which we'll talk about a little bit later. But states have been using the Section 1115 authority to design innovations and ask for waivers of certain provisions in the Medicaid law for many years. So this is not innovation. Medicaid reform is not new to most states. Prior innovations, though, mostly focused on coverage, increasing access to Medicaid, expanding Medicaid to populations that weren't automatically eligible, and to decreasing costs. In fact, some of the early Medicaid managed care waivers in the 90s, I would suggest, those were really about managing cost. They really weren't so much about managing care or improving quality. It was really how to manage the budget and get control of the Medicaid budget for the most part. Now states are embracing the tenets of what we call the triple aim. Better care and outcomes, reducing the total cost of care, and improving the patient experience. So states are developing new ways of organizing their service delivery systems, like accountable care organizations. They're called many different things in states. In Oregon, they're called community care organizations, and new payment models that go beyond the first generation of managed care. And that first generation were capitated payments per member per month, capitations for every person that a health plan or some other organization was responsible for. Well, states are really going beyond that traditional way of paying, and this is where you're going to hear about some of the innovations and reforms. States are saying to their health plan business partners, even in mature Medicaid managed care states, where everybody's been in a managed care plan for quite some time, the states now, state officials and state legislators, are saying to the plans, well, we give you this capitation, you take all of the risk, but then you turn around and you pay your providers fee-for-service. So you're not, the plans, you're not helping us change behavior. Plans, you're not really helping us change the system, and we need you to do that. And that's where some of the most exciting work is coming from out there in the field. So, to the panel, what can states do to influence or mandate what health plans do? How can states use their procurement processes, their contracting and procurement processes, and the decisions, and then in that contract language, to drive faster, deeper changes in the system? And can states work with the plans to offer quality incentive bonuses, gain sharing, upside, downside risk at the provider level, try new experiments with payments instead of fee-for-service, bundled payments? We've heard this in a couple of other sessions, paying for episodes of care like what Arkansas is trying. So we know Washington is experimenting, you have experimented with patient engagement materials and patient engagement initiatives to enable patients to be part of the discussion in their care, for them to own more of that decision-making using tools to help them decide whether they want a less invasive or less expensive procedure. Utah built the first small business exchange. That was a huge innovation of 13,000 covered lives today. Utah created one of the first adult public programs with an alternative benefits package before the ACA allowed for such a thing, and implemented a very unique funding methodology for accountable care organizations. So now what? How do state officials, elected and appointed, and civil servants come together and raise the bar again to reduce total cost of care, improve and maintain the quality of care, and really improve the patient experience and increase patient engagement so they can own their own health care? I'm going to start with some questions, and here we go. So to Senator Becker and Mr. Johnson, you've been a leader in this state for decades now. You've tried various things in your Medicaid program. You created the basic health plan on which the ACA offered that option to other states. The cost per enrollee of the new adult population being served in Medicaid here in Washington is actually lower than what was originally expected. So that's the good news. So why do you keep investing in reforms? Why do you keep, particularly in Medicaid? How do you all work together, and what are the challenges going forward? When sometimes you might feel like we've done all this, when are we going to be done?
Well, it is a pleasure to be with you here this afternoon. And in Washington State, I think the important context for any discussion with regard to the Medicaid program is with the expansion discussion and health reform in general in our state. It has been, as Joan was alluding to, a very bipartisan affair. The decision to expand Medicaid was, in fact, bipartisan. We have experienced lower than expected capitated rates for the new adult population. That's largely because we have twice as many new adults as we were expecting in the early goings anyway with our Medicaid expansion, which has actually helped the state achieve even further savings than was originally expected. In the first 18 months, Washington State saved over $300 million in its state budgeting process on account of the success of the Medicaid expansion. But that drives a new discussion and is driving a discussion in our state around the need to reform further. This perpetual need to reform has been made even more so by expanding our Medicaid program by 50%. In addition to that, a Medicaid program in Washington that used to serve two-thirds children, some low-income families and parents, and a fraction of disabled and elderly, is now a majority adult program. Over 55% of the enrollees in the Medicaid program are adults with very different needs, very different health diagnoses, and a delivery system, at least in the Medicaid arena, that hasn't necessarily been prepared to accommodate those needs at least fully. So the legislature actually has provided fairly significant policy direction for our state with the eye that transformation is what's going to sustain the program over the long term. And I'm sure we'll get to a few of those components as we go. But what's driving our Medicaid reform discussion is the fact we have a program that has grown way more than expected, a program that has shifted in terms of the clients it's serving and different needs demanding a different approach from both our state agencies as well as the plans and provider partners we work with.
Senator Becker.
Thank you. First of all, I want to be really clear that a number of these reforms happened prior to me being elected and Nathan being in his role. I've been here 7 years, so Representative Cody, Senator Parlett, and Senator Kaiser sitting out there have been involved in this for a lot longer than I have, and a lot of this we owe thanks to them. You know, when we talk about reform and why keep going on reform, I look at all my years in healthcare as an administrator and realize that you may do something today one way and tomorrow something's going to change and make it better and easier and more efficient. In the medical field, when I was an administrator, I had a goal of beating the budget by 10% each year. But not just beating the budget by 10%, but by beating the budget by 10% by creating efficiencies and doing a better job of providing care. I look at healthcare today and want to remind each and every person out here that healthcare is still about the patient first. From my perspective, that's why we're talking about healthcare. It's not about the dollars to me. It's about how can we make a better experience for that patient. I look at what we have today in Washington State as a first step. I don't know that I believe that a managed care or an ACO is our final product. I think each and every year we have to look at what can we do and how can we create a better experience and yet reduce those costs. So I don't think that Washington State will ever quit reforming and working on it. We're looking at prescription medications right now. Some of those, it's cheaper to do. We have a policy in Washington State of generics first, but we're hearing from around the nation that maybe that's not the best avenue 100%. Some of the brand names are cheaper now than the generics, so we have to take a look at that in the long run. That may be another change.
So would anyone on the panel like to comment on this question about, Medicaid programs partner constantly and daily and regularly and robustly with private sector? It is a public-private program in most cases, and will continue to grow the partnerships with health plans and other types of organizations as business partners to serve the population. So does anybody want to comment on, give some specifics to the audience about new ways you're thinking about that partnership and some of these new contractual requirements and the kinds of innovations that perhaps the plan partners are actually bringing to you as suggestions?
I think I will be commenting. So I think that's true. We will always be partnering with others in the private sector, and for Utah, it has actually been a very, very good partnership because we find the plans do have resources and have ability to be creative within their organizations. And what we really have done in our contracts with our, we call them accountable care organizations, are a couple of things. One is that you refer to our creative way of financing our ACOs. So we have statute that actually allows us to increase the reimbursement to the ACOs, but at no greater rate than the overall percentage increase in our general fund expenditures. And that was all laid out up front. They were very much a part of being involved in developing that methodology and supportive of it, so they know what the rules of the game are up front. And then within that, because they do have some limitations in terms of ever-increasing funding, they become very creative in terms of how to control costs. And so they are doing things such as adding more case management, being very innovative in terms of providing services to clients that technically under Medicaid we couldn't pay for because they're not Medicaid-covered services, but they're critical to controlling not only the cost of health care, but providing better health care for our constituents. So I think we have a very unique and very good partnership. And again, we put specific performance measures in our contracts. It's a very collaborative process in terms of the negotiation of the terms of the contracts. And it really, truly has been a partnership moving forward. So,
any other comments?
Sure. In Washington, especially with the expansion, we have 90% or more of our Medicaid enrollees served by managed care plans. We have 4 more national for-profit companies, 2 provider-owned nonprofit plans. I like to joke sometimes that the competition in the Medicaid marketplace is more significant and cutthroat than we experience sometimes in the commercial landscape, but it's actually pretty competitive in both places. One thing we leverage in those contracts, though, is a significant expanded access to care through demanding a level of network adequacy that simply cannot be achieved in the fee-for-service program. We, too, have performance measures that are included in those contracts, but one thing that I think was very important groundwork that was laid by the legislature in 2013 through House Bill 1519 and Senate Bill 5732 was the idea of Medicaid measures that would span Medicaid delivery systems, go beyond our managed care contracts, looking at the long-term care system and our separately managed care behavioral health system, looking at measures of health performance that are not exclusive to any one of those, but depend on each one of those delivery systems operating at their highest and best possible level. So we've included things through a stakeholder-driven process and we aspire to incorporating this into contracts, although it has not been done yet, things like housing status, things like criminal justice involvement. Given the new population, especially that we serve, it is impossible, I believe, to achieve the aims of the Medicaid program without getting very clear and very focused on some of those social determinants of health that we also need to be mindful of in the delivery system. But it is extremely so in this state a partnership with different types of plans and plans that are always competing for market share, and we think that brings a lot of value to the Medicaid consumer in our state.
Representative Dunnigan, did you want to comment?
To your broader question of why do we continue to work on this, and as you said, we've been working on this for years. We have an 1115 waiver that we got some flexibility under the Bush administration that we would not be able to get today, but we still have that waiver in effect. In 2001, Medicaid accounted for 13% of our state budget. So now 14 years later, it accounts for 23%, and it's continuing to grow. And I've heard some of you speak, and in some of your states, it's even a larger percentage than that. So that's 9% above the state budget that could be going for public education, roads, transportations, corrections that we're putting into Medicaid. And so it behooves us to try to find effective ways to address it. And as Emma alluded to, 2.5 years ago, we started accountable care organizations. So these are managed care organizations for Medicaid, and the health plans are at risk. And we wanted to bend the cost curve. We don't think we had any hopes that we could actually decrease the overall cost, but we wanted to bend. We saw the forecast going like this, and we wanted to bend it. And we've actually been able to do that over the last couple of years, and time will tell if we continue to do that in the future. But it's been working the last couple of years. We did it in the urban area, the metropolitan area of Utah. Now we're expanding it to the rural areas of Utah, and we're hopeful that it will continue to work.
Great. Okay. Next question. Sometimes the needs and wants of your constituents and stakeholders don't exactly match up with what the data are saying. The story that you hear from people in your own neighborhoods or people who write you letters or at town hall meetings, the stories they're telling just aren't supported by the data, or the number of people that seem to be impacted by a problem seems very, very small. So, for instance, a constituent might bring a problem to you and feel it requires new or additional regulation. They had some kind of a bad experience with a provider or system, but after you've investigated this, or you've asked the departments to investigate the problem, it appears to be kind of an isolated incident. It doesn't seem to warrant broad new rules or regulations. How do you manage that? How, as elected, particularly the elected officials at the table, and for the department staff, how do you respond then to the community and the stakeholders and make program and budget decisions when this kind of thing happens?
Thank you. what has been interesting is we don't have that sort of incident just in healthcare. That, of course, is about every aspect of how we live as a legislator. What we do when something comes into our office and we don't have a response because it is a new thing, my legislative aide then approaches staff and the folks that are in those agencies and finds out what the reality is. And if the reality is different than what the person is talking about, then we talk with that person. We find out what their perspective is in more detail. The thing that I have found is we created legislation one of my first years on a person who found a loophole when Nathan was my staff member and their son had committed suicide, and there was a loophole that was in the law, and that we corrected that. But it had not been for that due diligence, we wouldn't have known if it was a reality or not a reality. Sometimes those complaints or those thoughts that people bring forward are realities, and we'll get one complaint, but all of a sudden we're getting more complaints. And what we found when we had our Joint Select Committee hearings last summer is on our exchange, for example, people were paying their premiums, but they weren't being forwarded to the exchange or to the carriers, and so we had to change premium aggregation from there. So that goes both ways. And I think the most important thing is to take a look at what is being said and see what you can do, and if it's already been done, talk to that person and tell them what has happened and are they satisfied with that, and could they look at it in a different perspective, and have we met their needs?
Well, and it can happen with innovation. Somebody brings you an idea and you say, wow, this sounds really good to me, and then you start running it through the traps, and it's probably not quite as good as they make it sound. Representative?
Well, if I get a constituent concern or complaint, the first thing I do is turn it over to my chief of staff, which is, yes, that's myself, of course. We have a pretty slim organization, and we run a tight ship in Utah. But as Senator said, many times it's a wide variety of issues, as you all know. I had a gun one recently. A person was very upset that our state law did not allow gun stores to buy back guns, but pawn shops could. He was furious. I thought he was going to shoot me. He was really mad. But so we just did some study, and we looked into the law, and it actually turns out that gun stores, including Walmart and others, can actually buy back, but they're subject to a 30-day holding period. They can't sell the gun for 30 days, and most of them don't want to play by those rules. So a lot of it's education. Another one involving health care is we've heard complaints for some time from advocacy groups and some constituents that said on behavioral health treatment, if a person ends up before a judge and a judge orders a person to have substance abuse treatment or something like that, that the health plans won't cover them if it's court ordered. And so this is a common thing for a couple of years. So last month I chaired the Health Reform Task Force. We had all of our commercial carriers come in, and we had them testify of how they cover court-ordered behavioral treatment, and they all said they would cover it. So, whether or not that's true, we have them all on record now, and that they will cover it. But a lot of it's just educating, and you're right. Many times somebody has misinformation, or they think something's a wonderful idea that's really a terrible idea, and we have to kind of work with them.
Well, there is a lot of urban myth in the Medicaid program, and our next question is going to be about the Centers for Medicare and Medicaid. And oftentimes people say, well, we can't do, CMS won't let us do that. And then when you really dig into it, or you have a conversation, you find that it isn't a rule. It really isn't it's not embedded in law. You can ask for things. But proposing innovations or creative ideas to the Centers for Medicare and Medicaid that vary from current standards or regulation is a mixed bag, even for the CMS officials. They love the creativity and innovation that they're seeing coming out of states right now, and they appreciate very much how states want to experiment, but they are also accountable. The officials that the state folks work with are accountable to the Secretary of HHS, they're accountable to the White House and the Office of Management and Budget, they're accountable to Congress, and they're accountable to very powerful stakeholder and special interest groups as well. But we all know how hard it is to get through these waiver conversations and budget negotiations when we want to do something really, really unique. So how have your states worked through this? Again, both individually in your roles within the Medicaid agency, but how have you worked with your legislators to help make the case to CMS for something really interesting that you want to try?
I'm actually just fresh off 5 public forums throughout our state on our pending waiver application. So this is a very timely question. And going back a little bit, the Center for Medicare and Medicaid Services has created an entire program to reward and encourage state innovation, the State Innovation Model Program. Our state's lucky enough to be participating in the testing grant side of that, and that's certainly enabled some of our initial efforts. But we found out very quickly that it's additional federal flexibility and, frankly, federal investment that will be necessary to achieve the policy objectives the legislature set for our Medicaid program. So that's what we're working on. And as a bit of context, in my office, I have bookshelves that at one time were full of decades of failed waiver attempts, actually.
Binders.
We have a strong tradition that predates any of us anyway of pursuing flexibility from our federal partners only to have an administration turnover or to have a great idea bounced back or to have so many layers of bureaucracy applied to it that it's impossible to move it forward. One of the very exciting things about the waiver process that we're involved in now with CMS actually started with some help from the National Governors Association. They provided a technical assistance opportunity to 3 states, and we were one that was lucky enough to receive that TA. And what they actually brought to us was CMS senior leadership at the very front end of the conversation, to hear what we're doing already, to hear some of the concepts being floated and the policy direction already established, and to have some of those preliminary discussions that we just weren't able to have in prior efforts. And I think that set us up to the point where we have a draft application circulating now for stakeholder review, and we'll file a formal application later in August, where we're assured of a legitimate negotiation process, and we're assured of a CMS organization that is well attuned to what this state is trying to achieve and the policy direction that it has set. So I'm quite encouraged that this will be a slightly different effort, and perhaps for our state at least, different from Utah, the first real comprehensive 1115 waiver we will ever secure for our Medicaid program. So that may sound a bit optimistic, but I think it's a very different process that CMS is now considering and weighing, and I'm quite encouraged by it.
Great. And Senator, how is the legislative branch involved in these efforts, and at what point do you get involved?
Well, we have our Joint Select Committee meetings during the interim, and we already had a Joint Select Committee meeting, and that is different members from the House and the Senate, and I think there's about 8 of us on that committee. And we had Nathan and the rest of the folks from the Healthcare Authority come and present what they were proposing to do on this 1115 waiver. Now, on the 1115 waiver, we learned it took a little bit longer for us to learn, and we asked a lot of questions about the processes and where we are as legislators. What our processes are when they go for that, and what we have to do is approve that legislatively prior to implementation. So there's a checks and balance in this process.
That's great. And Utah, what's your experience?
I'd like to comment on that as well. So we have had our 1115 waiver for many years, and we have actually had a fairly good working relationship with CMS on that waiver. But more importantly, as we're looking at expanding Medicaid in the state of Utah, we've had a very similar experience with CMS, where we have been actually meeting with CMS officials at the highest levels of CMS on a weekly basis for almost a year, negotiating, discussing, talking very logically about the reality of where we're at in Utah, trying to come to some understanding and agreement. And actually the experience, although we're not there yet, I think has been a very open one. They very clearly tell us where they feel that they have to draw the line, and we very clearly tell them where we feel that they have to push it. And as a result of that, we've had not only these weekly negotiations, and we will continue to have negotiations with CMS, but also our governor and actually Representative Dunnigan have met with Secretary Burwell and had discussions with the head of CMS on several occasions. So I think, again, it's been a very collaborative process between our legislature and the executive branch, and we just continue to have these discussions and try to get CMS to understand that it is in all our best interest to come up with something that meets the needs of the state of Utah as well as meets the needs of CMS, because our mutual goal is to make sure our residents, our citizens have health care, and that's their goal as well. Again, I think it's been a very collaborative process, and I'm hopeful that at some point we will also have an 1115 waiver. We're going through a similar process where we're negotiating it up front, hoping that that will expedite the process later on.
I'd like to ask the audience a question. I'll hold it. Do we have any folks from CMS or HHS in the room? Okay, good. And I know this, we're televising it? That's not good. So we love the folks at CMS and HHS. And Utah has not expanded Medicaid, but like many of you, we are in the throes of this. And during our session, which ended mid-March, we were deep into it, and we worked collaboratively on this. You know, the majority party with the minority party, with our departments, you know, and Emma and her folks are terrific to work with. We work with the governor's office. I'm in the House from time to time. We even work with the Senate, and we try to bring all the parties together. And so we had a conference call with the D.C. folks and their top-level folks, and we're saying, we want to know what we can do. We're trying to see if we should do Medicaid expansion. What can we do? And they say, well, it's like a treasure hunt. You know, that's what they said, can you tell us yes or no? And they say, well, we're not sure if we can. I said, just tell us yes or no. And they say, can we do this? And they say, well, we probably we'd have concerns about that. And I say, can we do this? And they say, we'd have more concerns about that than the prior concerns we had on the other one. And we got up to 3 levels of concern, and then it was an hour discussion. We finally got 2 no's. And, you know, we didn't want to hear the no, but finally we got an answer. But they'd say, why don't you go look at Virginia? I would say, why should we look there? And can you tell us, is it bigger than a bread box? And they'd say, well, you know, start looking at this. And look at Wisconsin. And look at Indiana. And it's like, I get the feeling that they're standing in this room back there and they got 20 police over, you know, HHS police looking over their shoulder saying, you cannot give away the store. We only have so much candy and you need to hold on to it. And so we have to connect the dots. And 3 months ago, I went with our governor. We met with Secretary Burwell and the new director, Vicki Wachino, and their top-level folks. And we said, tell us what the parameters are in Medicaid expansion. What are the fence posts? And they said, tell us what you want to do. And we said, if you'll tell us what the rules are, it'd make it much easier to know what we can do. I said, tell us what the fences are. And they said, Secretary Burwell said, I'm afraid that if we tell you what the fences are, that you'll try to build a ladder to go up and over the fence. And we won't know how high we need to build the fence. And I said, I'm going to be up front with you. If you tell me where the fences are, not only am I going to build a ladder, I'm going to build it away from your guard tower so you won't be able to see us when we go up and over. But I like Secretary Burwell. She's got a private sector background. For me, it's a breath of fresh air in that office. We were trying to get a work requirement in our Medicaid expansion proposal, and we worked and worked and worked. And finally, on this face-to-face, she just said, I understand you want our governor. I was there. He made I thought a very good case for it. And she said, I've talked to President Obama, and he has informed me it's not his policy. That is not his policy to allow a work requirement. Even though, particularly in Utah, you know, you have a good work ethic. You have 3.5% unemployment right now. We think it makes a lot of sense. That's not his policy. And so that goes back to your point. They have their masters to answer to, just like we do. We answer to our constituents. We're continuing discussions with them. And you know, in that same meeting, we had a discussion about 1332. It was the same question. Tell us what the rules are. Tell us what the parameters are. And even though they came out with their kind of guidelines, they're still pretty nebulous. And they said, we're waiting for a state to submit a plan, and then we'll tell them that if we're going to approve it or not. That's hard to put together without knowing what the rules are, but that's what we deal with, and we'll continue. I can tell you one other quick one. Our former governor became the secretary of HHS. How many of you would like that? Your governor, majority party, party became the secretary of HHS. This was several years ago. Well, we thought we had gotten the key to the vault, you know. I mean, right? All these waivers that we've been told, you know, the frustrating thing was a waiver. It takes us 1.5 to 2 years for them to tell us no. You know, just tell us in a month, you know, don't make us keep trying. So we submitted all this stuff, went to the secretary, our former governor, and by the time it filtered out through the bureaucracy, it was no. I mean, that's when our former governor was the secretary of HHS. Imagine that. I better stop right now.
Well, we're going to come to 1332 waivers in a second, but I will say the one thing that impresses me about these stories that I think is sort of new in these conversations is the fact that the governors themselves and taking legislative leaders and sitting down in person with the secretary and high-level people, that's who's pitching and negotiating the waivers. You did not see that happening a whole lot 10 years ago. Rarely would a governor personally or take a legislative leader with him or her personally to negotiate that waiver. They sent their Medicaid director, Medicaid staff. So I think that's very important. I think it's critical that the leadership in the state say, this is what our state needs and this is what our state wants. So I really do wish you continued luck in trying to figure all that out. You mentioned 1332 waivers. So some people call them Wyden waivers, some people call them 2017 transformation waivers, but it is a provision in the Affordable Care Act that, and I'm going to paraphrase because the guidance did come out, but the intent, what we think the intent of these waivers, 1115 waivers can waive a lot of provisions and requirements, but they cannot waive everything. The authority of the Secretary to use the 1115 does have limitations on it. But the 1332 waiver provision was really written, we think, to say to states, okay, you did what we asked you to do in the Affordable Care Act. You tried it our way, the way it's written in the Affordable Care Act. Now, if you really want to try it your way, you can write a 1332 waiver and really reform health care in your state in the way that you believe is the right way for your state. Now, you can do that, but you have to cover as many people as you were covering under their way, and it can't cost them, no waiver can ever cost federal government any more money than they were going to spend anyway. So how are you guys thinking about 1332 already? Have you started? What is the next big thing that you're thinking about? Washington, you have a goal that by 2020 the managed care organization contracts will be fully integrated and that performance measures across plans will be aligned. You're developing accountable communities of health. What do you want to see happen from this in Utah? What are your goals and challenges over the next several years? What if you don't get that 1115? Are you going to take a shot at a 1332 waiver?
Well, honestly, I think we've looked at 1332s, but our understanding is that 1332s are really intended more to reform the commercial market and still need to be done in conjunction with an 1115 for Medicaid and potentially CHIP. So I think at this point our focus really is, I think, on the current negotiation that we have. And then I think there are other things that we need to look at, one being the integration of behavioral health and physical health care, which I know Washington has already taken that step in a major way. Utah hasn't done that yet, and I think that's something we still need to look at. And then the other issue that we're focused on, particularly for children right now, is better preventative oral health. We can see a lot of benefit in that, and we're working closely with our dental plans actually on that particular initiative. And Utah is one of 5 states that's currently involved in an oral health initiative with CMS. So those are our more immediate issues that we're looking at this point.
Yeah, I'm glad you pointed out that even if you go for this 1332 provision, it probably for most states is going to mean multiple waivers. So you're absolutely right about that.
At that same meeting we had with Vicki Wachino and Secretary Burwell, I asked them about the 1332, and as you know, they were very clear that that's for the commercial market, and that I said, well, can we combine a 1332 with 1115? And they said, oh, that's an interesting idea. And it's interesting because we had submitted, they wanted our question submitted to them ahead of time. They knew I was going to ask that question, but they're careful, they're measured, and as you say, they have many bosses. But one of the things we're working on is integrating physical health with behavioral health, and we want to do that for our Medicaid population. Now they're in different silos. We have accountable care organizations that provide physical health, and then county mental health facilities provide the behavioral health and substance abuse, and we're working on a pilot to try to marry those two.
What about Washington?
Well, I have a few different opinions on the 1332 waiver. We had a bill that was presented that would have been a very narrow 1332 waiver that would have enabled farm workers to be able to get insurance. The only thing is it was so narrow, do we want to take all of our capital and work on just that one aspect? If I had my dream come true on the 1332 waiver, it would be looking at those folks that don't get the subsidies, that their premiums have gone up 50 and 60% in some cases in our state, and that we would look at how can we reduce those premiums and their deductibles when they're paying premiums for catastrophic insurance where they used to have a smaller deductible. So if I had my druthers, that would be one of the main things. One of the things that we are doing, though, in the integration is we're working with the University of Washington, and a number of you have probably heard of Jürgen Unitzer. And we have actually created more slots at the University of Washington for more psychiatrists. And his program is already working in some of our community health centers and the university centers where they are utilizing psychiatrists. He says there's 600 and some psychiatrists in the state of Washington and 570 of them are in Seattle. How do we serve the rest of the state? And so what he's done is he's created a way that actually takes those psychiatrists and they work with physicians' offices. They train people that are LPNs, MAs, in that type of thing with strict protocols so that they can ask questions of the patient, say a week after they've given some treatment, where they are and how they're doing, and then that's called back to that psychiatrist, and that psychiatrist can then help those people, and he's getting outcomes. So that's one of the ways that we're looking at the mental health integration, and I'm really excited about that because he actually has a program working. But with waivers, I'd like to look at on the 1115, and I would encourage an expansion of our Medicaid waiver to look at having people have the ability to go through the commercial market and be able to take a bigger role in purchasing or making those medical purchases decisions that will actually give them the ownership of their health care and give them more ability to participate.
You mentioned a few of the initiatives we are chasing after with the waiver, and just briefly wanted to provide some further context. And one of the things that we think differentiates a bit Washington State's approach from other previous delivery system reform approaches for Medicaid is this idea of getting after, with more than rhetoric, the 80-20 proposition. This idea that 80% of health are determined by factors outside of the clinical care delivery system is something that stymies us because 90% of our dollars actually go into the 20% side of that equation. And having those two sides of the equation work together at the community level is something we're quite serious about and invested in. And one of the initiatives to provide some structure to that is accountable communities of health. And under our waiver proposal, accountable communities of health, which stretch multiple sectors in the healthcare delivery system and in the social services sector with community-based organizations, housing, education assets, and others at the table, giving them ownership over decision-making and the governance of significant federal investment in our delivery system reform is where we're headed. And one of the further elements of that is thinking of integration in particular. Washington State has made the leap to basically dictate that by 2020 we will have a fully integrated managed care delivery system in our state with physical and behavioral health services rendered through the same managed care delivery system. One thing that we know requires significant investment and a significant further leap from the community side of things is the actual delivery system investments that need to be made. That is to say, integrated care models and implementing them well and with fidelity to what we know works. And Senator Becker was alluding to Jürgen Unitzer's work at the UW Ames Center, which is some of the most, I think, I'm biased perhaps, but some of the most impressive work on this issue in the country. We have great evidence of this in pockets. The scale and spread of integrated care models will require something more of us and more of our federal partners, and that's one of the real aims we have under our waiver, is to demonstrate that the policy direction is secure, but we need significant investment, and we believe we can prove to our federal partners that with that investment we will constrain overall cost growth in Medicaid over the 5 years of our waiver. So that and a few other things are what's really driving us, and as the Senator suggests, we are in an open stakeholdering process where other ideas are certainly being brought to the table on what an 1115 waiver might be able to accomplish.
Great. Very exciting. Is there anybody in the room from Vermont? Well, I'll just mention, you may have read that they had planned from the beginning of the ACA. They had been talking right from the start about eventually using the 1332 provisions to write a waiver to develop what they were calling a Vermont version of a single-payer system. And their thinking was, if you look at the number of people in Vermont and you look at the people whose coverage was paid for by a government dollar, there wasn't too much left. They started down the road. They were planning that and then could not get the kind of buy-in that they needed both politically and from the private sector. So as far as I know, their plans are on hold for the moment. Who knows how that will change down the road. But a couple of other states have made a little bit of noise about this, Arkansas, Hawaii. So it'll be interesting to see once the guidance actually comes out and this waiver will be available for 2017. We'll see which states actually use it. Okay, so we alluded to this a little bit in this conversation about personal responsibility and patient engagement and social determinants of health, the things that we do ourselves, choices we make, behaviors we engage in that impact our health and health care. So we all want consumers to be more engaged in their care and have more skin in the game, figuratively, of course. I know that Washington has put together a first-time user's guide on what is covered, how to make clinic appointments, what does insurance mean. We know that many of the people that in states that did expand Medicaid, many of the clients that are coming into the Medicaid program for the first time, or even people who are going buying marketplace products, either have not had insurance for many years, and some have never had insurance. They really do, and if they had insurance, it may not look anything like the insurance of today. So consumers are confused, and they're not walking in the door all knowing exactly how to use this policy and how to use the system. In Utah, you have worked long and hard, I think, to provide quality, affordable coverage to small employers and dependents through your original shop. So what would you want to do to increase the healthcare literacy and engagement of people so that they really understand what it means to have insurance, they know how to use the system, they're using the system for prevention and intervention, not still going to the ED, not still waiting until they're really sick? How can we really increase the engagement of people to take personal responsibility in a way that actually improves their health and doesn't become punitive for the consumer?
In Utah, we've done a couple of things. I'm sure that's working right now. There we go. I'll grab that. So for quite a few years, we've also done a similar thing where we have prepared a member guide for our Medicaid members that gives them all the information about coverage, co-pays, resources in the community in addition to Medicaid. And then we also have staff that are state staff. We refer to them as health program representatives, and their role is actually, number one, to assist individuals in selecting a plan. And as with Washington, about 80+% of the individuals, Medicaid and CHIP, in our state are enrolled in managed care. So our health program representatives are actually available to help families find the appropriate plan, especially if they already have a provider network that they're dealing with. And they also are there to help answer questions for our constituents, intervene between the constituents and the plan or providers, assist providers. So I think that's something that we have done for many years and will continue to do, and we're expanding the role of the health program representatives. The other thing that we do is we do face-to-face orientations that we provide for our constituents. And then in Utah, we are a very tech-savvy state. The majority of the citizens of our state are very technically knowledgeable. They may not have computers, but almost all have smartphones, and so we are looking at building a member, what we refer to as a member portal, that will provide a lot of information for our clients, making those smartphone available, and going to YouTube videos. I mean, we're looking at everything we can just to try to educate our constituents and help them through that process. And then our plans are also very much also in that mode. They have care managers. They're assisting not only their enrollees in terms of making these decisions, but they also all have different incentive programs where they're trying to incentivize individuals to focus on wellness, focus on preventive care, and again, take more control of their own health care.
Great. Other comments about that?
I'll just add just a quick few. In terms of the outreach and enrollment side of things, one of the things our state has done that I think is fairly unique is we have introduced Medicaid plan selection through the exchange. Our exchange actually for all MAGI-eligible individuals, which is most of our Medicaid population, is the eligibility portal, so it's fully integrated. But when we first launched our coverage expansion, Medicaid members would still just be assigned a plan, and their selection ability was kind of after the fact. And after a significant and arduous process, once you build a system to amend that system, just 2 months ago, introduced for the first time to our Medicaid consumers a plan selection opportunity in the eligibility portal, and so far so good. And the response is great, and it gets Medicaid consumers invested in that initial decision, which is a very impactful one, about which managed care plan, oftentimes they have up to 5 choices, they're going to land, and which provider network, by that same virtue, they're going to participate with. One other element of our broader, what we call Healthier Washington initiative, is on the clinical side, and that's shared decision making. The legislative leadership from Washington that's in this room several years ago now introduced legislation, another kind of first-in-the-nation effort to tie the use of patient decision aids at the provider's office to an actual improvement in terms of their liability for purposes of certain lawsuit situations. And unfortunately, some of the science and evidence for shared decision-making has lagged a bit. The policy direction, one of the very exciting things in the state innovation model effort, is actually implementing shared decision-making through our state purchasing and helping both providers and patients have real discussions that actually both of those entities want to have, and providing them some tools to have that discussion, and then rewarding them through the statutes that already exist for having those very important and weighty discussions in the provider's office. So more to come on that front, but that's another way we're trying to engage the 2 million or so folks that we serve at the Healthcare Authority. And
I was under the impression you had some pretty promising data that shows if you give the patient, a neutral and complete set of information about their choices, would you rather have surgery or physical therapy, and if the outcomes are going to be the same, that you're pleasantly surprised as patients often pick the less invasive and cheaper pathway.
A real state pioneer on this for us has been Group Health Cooperative, and they've been using shared decision-making now for some time, and the evidence would suggest that, yes, when you present patients with the evidence and they're able to have an informed discussion with their provider, they'll oftentimes make a very, very different decision than they would have at the outset. So a tremendous amount of promise. The science has advanced, the literature has advanced, and now we're trying to implement it through our purchasing effort.
Great. Any other comments on that before I move to the next? Yes, go right ahead.
Thank you. Well, I don't want to put a damper on anything, but I think that when we're looking at patients having access to care that they haven't had before, and going into a doctor and knowing how many people have actually gone into those offices, how many have actually had their immunizations, how many have had their preventive care, et cetera. We implemented in Washington in the original Medicaid expansion, and then went a little further with it this year to make sure that we get reporting back. My fear was from my years ago in working for a hospital in early MCO, is that we had more underutilization than overutilization problems. So how do you make sure that the people are getting those services? And so we put in place reporting mechanisms so we can check that as well as doing all of the other things.
Great point.
One of our, Emma's talked a little bit about the outreach education, which are very needed, and for many people, particularly some of the newly insured, this is a foreign arena to them, and you have to educate them how to navigate that. One of the areas that we need to work on is utilization of the emergency room as a primary care facility, and one of our state senators, Senator Shiozawa, is an EDAR, emergency room doc, and so he provides a good perspective for this. But so we've tried to work on benefit design a little bit and try to have lower co-pays if a person has an emergency, goes to the emergency room, and higher co-pays if it's a non-emergent condition, go see a PCP or let us help you get a PCP. And we petitioned CMS to allow us to, our ER copay I believe was $5 for non-emergent. This is a non-emergent ER, and just quickly, last year our average emergency room visit was about $1,400. So of course some are more, some are less, but about $1,400. Our average urgent care visit cost is about $140, so it's 1/10 of it. And much of what takes place in the emergency room, which I believe could be taken care of in an urgent care facility. So we petitioned CMS to allow us to raise the $5 copay for non-emergent to $25. And they said no. And we said, well, we want people to have coverage, but we want them to get appropriate care. So we worked on it, and they finally came back and they said, we've heard you, we're going to give you flexibility, we're going to allow you to raise your copay. And we said, yes, the heavens opened and the sun came through. And they said, and drum roll, we're going to let you raise it all the way to $8. And we said, okay, thanks. But it was a big deal. To them, it was a big deal. And that's not much of a disincentive, and yet, and I don't want to speak for Dr. Shiozawa, but I think many people would be better served and get better care by going to see a primary care physician or even an urgent care facility than trying to go to the ER. So these are things we have to continue to work on.
Absolutely. So you've mentioned you named group health. Utah, you have Intermountain Health Care. Washington has other high-performing systems, as other states in the room, well-known systems of care, integration. They get the quality measures. They get all the star ratings, Geisinger in Pennsylvania, Cleveland Clinic, Mayo, et cetera. So in what ways do these major integrated systems influence state policy? I mean, these are different than plans. These are big integrated systems. They have a lot at stake here. They're plowing through all of the reforms and new regulations just like the rest of us. How do you work with those systems in your states?
I can take it. We naturally have been focused on Medicaid given the subject matter, but one of the ways we're interacting right now in our state with integrated delivery networks is with what we're doing on the public employee side. And in 2016, for the first time, we'll be launching an ACO product for public employees in the greater Puget Sound region. And those two contracts are with two high-performing integrated networks, UW Medicine and the Puget Sound High Value Network, which is driven by Virginia Mason and Evergreen, for those familiar with some of our health systems. And they have extended networks, both of them do, beyond that, and given the geography they're serving. And one very important element of those contracts is more than just signing another kind of managed care vehicle, which you could certainly fall into that trap, trying to move this along. These vehicles ensure several things. One, a level of care experience to our public employees that is superb and best in class, and follows some of the care transformation principles that have been established as community standards in our state through something we call the BREE Collaborative, which is a multi-sector universe of folks getting together to discuss evidence-based practices. One challenge has been they've discussed them, they've developed the standards, but the uptake has been very slow. So we're encouraging that uptake, not just encouraging it, but compelling it through our contracts. The other thing we're doing with some core performance measures that, again, have been defined at a state level is introducing those measures and the financial shared savings and shared risk model to go with them, where continuous improvement is what's awarded. And one thing we've strayed away from in these contracts is a gated methodology where you reach a level of performance and then you're smooth sailing. We want to see up to the highest possible level continued improvement of our delivery systems, and we'll be measuring them as such over the course of the contracts that we have signed. So it's an exciting launch, and with these products, folks are going to be opting in. It's not an attribution methodology here. People will be selecting and enrolling in these new plan offerings and seeing a significant premium discount and reduction in their cost sharing should they, in fact, choose them. So we're excited. This is one of our major tests under the State Innovation Model Test Grant that we have, and we're excited to see expand to other purchasers in the state. So one thing we're definitely trying to do is figure out how that applies. The same principles apply in the Medicaid universe, which is a bit of a different business model.
Well, I think this is where you might see a 1332 waiver combined with an 1115. And there are a number of states, you have to remember it's not just the Medicaid expenditure that's hurting the budget. There are state employees and retirees that are putting huge pressures on the state budgets as well. And I think that's where you might see some very interesting things come out of 1332 to try and put these markets together and drive change. What about your systems, Intermountain and other high-performing systems that you work with here over in Utah?
Interestingly, so Intermountain, the entire Intermountain system. So we actually, in Medicaid, we have 3 plans that are actually, we have 4 plans, but 3 of them are actually integrated systems, which makes that very interesting. And one of them is basically Select Health, which is part of the Intermountain system. And they have close to 45% of our Medicaid enrollees, and obviously are a large player just in the state as a whole. And I think what is happening is Intermountain Healthcare on their own has decided to look at restructuring their system, because whether it's Medicaid or public employees or the commercial market, I think our systems are realizing that they are going to have to restructure and refocus what it is that they are trying to accomplish in order to continue to be viable and strong systems. And so Intermountain Healthcare on their own basically decided that they wanted to redesign care and, much like Washington, focus on evidence-based care. And so they really have undertaken sort of a mantra of right care, right setting, right time. Again, not over-treating, not under-treating, but providing the appropriate treatment, aligning financial incentives even within their own system. And so they have actually decided to reorganize into regional organizations where everybody in their own system is a stakeholder. And this is important for our system as a whole, for our state as a whole, because they have 1,400 providers in 22 hospitals, and even our other plans have to contract with their providers in order to have enough access to care. So this is influencing our entire system, and then they also are focused on engaging patients. So they, along with our other integrated systems, have recognized this, and they're also implementing very similar initiatives. And that is having, I think, a positive impact on Medicaid, because that is influencing how they're administering the plans as well. And one of the things that I wanted to mention earlier is our first year of the accountable care organizations, we actually ended up with around a $17 million savings that we were able to put into what was referred to as a Medicaid stabilization fund that was also a result of the legislation that created our accountable care organizations and our budgeting methodology. So we're seeing some real tangible results in terms of actual savings in our state as a result.
That's great. Representative, did you want to say anything? So I'm going to open it up to the audience now. If you have questions, please come to the microphones in the center of the room and ask whatever question you have. If it's directed to a particular person, please say so. If not, if you want the whole panel to respond, that's just fine. And please tell us your name and where you're from. Thank you.
My name is Gary Blumenthal. I'm at the National Council on Disability in Washington, D.C. I'd like to ask the panel, with respect to Medicaid, it's also a payer of community services for individuals with disabilities. And a lot of your reference to health care is changing behavior to achieve better outcomes and to achieve cost savings. For individuals with disabilities, better behavior will not reduce the need for a personal care attendant, and it will not cure an individual with a developmental disability. So I'm kind of curious how, could you comment on the impact of managed care and Medicaid savings that you're trying to achieve and what the outcome has been for long-term supports and services and what your plans may be. Just any comments on that?
Well, in Utah, we have not integrated long-term care yet in our system, and we also have numerous waivers that provide those additional services to specific populations. And also in Utah, we have always enrolled our disabled individuals in managed care. So what that is requiring is a lot of coordination between our managed care plans and our waivers. I think it's just a matter of actually meeting routinely, and we get down to the point where we're actually staffing specific cases and individuals to make sure that their needs are being met. So, you know, this is a population I think we can still find some savings to making sure that they're getting the appropriate care that they need. But this is a very complex issue, and whenever we have sat down and actually met with our stakeholders, specifically with regards to our enrollees with disabilities, it becomes a very complex issue because it quickly gets way beyond health care. So it's an ongoing challenge, to be quite frank. But I think it's just a matter of paying attention and working through the specific needs that those individuals have.
I'll say, different from Utah, we didn't have any of our disabled population in managed care until quite recently, actually in 2012, on account of a legislative directive to do so for actually at budget reasons at the time. It was through a budget proviso. And we made that change, and I think it was for the right policy reasons. Of course, there's budget drivers on decisions like this, but asking a person to navigate a fee-for-service system that oftentimes lacks adequate access to care on account of it being a total opt-in system for providers, we're actually much more assured today, 2 years after or 3 years after this initial transition of disabled populations to managed care, that people are actually getting access to needed services because someone's looking out for them. They're just not out trying to swim in a vast ocean of fee-for-service providers who may not always be willing to take that Medicaid card. So we've seen also as a result of that change significant savings and different utilization, right? The utilization has shifted from kind of very unfortunate outpatient and inpatient services that could have been avoided to more upstream, more primary care-oriented interventions. The other thing I'll say quickly is we have the second most rebalanced long-term care system in the country, but we also have a looming age wave that's hanging over all of our states and over all of our budgets. And tying it back to our Medicaid waiver approach, one of the things we're trying to do is look at people who are at risk for actually going down the impoverishment path to get on Medicaid initially and figuring out better ways of serving those people through unpaid family caregivers, for instance, which are 10 times the amount we spend on long-term care is the value of unpaid informal caregivers and supports in our state. So trying to keep people actually out of the long-term care entitlement but leverage some Medicaid savings and investments to do so is one of the specific channels we're pursuing in the waiver. Our fear is short of doing this, and with the age wave, we can have the most rebalanced long-term care system in the country, and it's not going to save itself short of other interventions aimed at this population. So I think you're asking the right and timely question.
Nathan, would you give the audience a 30-second definition of what you mean by rebalancing?
Oh, sorry. Yeah, sure. When I say rebalancing, I mean moving people out of facilities, nursing facilities and long-term care institutions to home and community-based settings, and we've done that in our state through 1915C waivers primarily, both on the developmentally disabled side and for our elderly programs.
Thank you. Other comments on that question? Other questions from the audience?
Good afternoon. Della Bellotti from the state of Hawaii. First of all, I am just so impressed with what Washington and Utah is doing. My question is directed at Nathan Johnson. Part of the reason why Hawaii failed at our state-based exchange is we didn't have the technology to do the integrated enrollment and eligibility, and we just didn't have the covered lives that the larger states have, and we have some other unique things. But so my question is, when I hear you say that you guys are doing integrated enrollment and eligibility and you're doing Medicaid plan selection, what comes to my mind is, one, how are you paying for that technology? Are you using it through the 90-10 match? How is it then integrating with your exchange, which is drawing down funds and drawing in people who are from the private market insurance? And now when I hear you say that you're bringing on your public employees to, I'm assuming, using the same technology, the questions that make me sweat are, how much is all that technology costing you in general funds? How much is it costing the federal government in the 90-10 match? And is this something that becomes unsustainable when you start talking about all of the states moving in this direction? Because we in the state of Hawaii, frankly, we were shelling out millions and billions of taxpayer money, and I don't care if it's general funds or federal money. But are we talking about what's going to be part of the exchange or a part of the reform nationwide is going to be the federal government investing in contracts for very select few, what we are calling the DC bandits in our state? How do you get control of those technology costs?
That's a fabulous question, and certainly the implementation of the Affordable Care Act has come with significant IT constraints, challenges, and costs, and Washington is no exception. And as Senator Becker was alluding to, we did have our challenges, but I would say, especially on the commercial market side, the implementation of MAGI eligibility for Medicaid was actually fairly smooth on account of some fairly significant policy decisions that were made early in the process. And that's what saved us, is we did have a Medicaid eligibility system that for the most part was working and managing the exceptions, and that allowed us to focus in our state on the energy necessary to correct some of the pitfalls of any startup of this nature that were especially true on the commercial market side and especially tied to some premium aggregation challenges. Speaking to how we're paying for it, there is, of course, in CMS land, the issue of cost allocation. So Medicaid is required to pay its fair share of this integrated eligibility system. Medicaid was required to pay the full costs of implementing Medicaid plan selection, those costs at least that were distinct from what had already been built out for the exchange, and as you mentioned, most of those costs were reimbursed with 90-10. I would say identify very much with your remarks, though. It doesn't matter what the match rate is. These are tax dollars. These are significant resources, and we're very, very mindful of that. I think one thing we've tried to avoid in the build-out of our exchange and our eligibility approach is some of the, frankly, mistakes of the past, both in our state and others, with major MMIS system installs, some that have never came or come on board. And I know many states have struggled with this. So we learned a lot. We did an MMIS conversion that worked. It took 7 years, but it happened. And so we learned a lot.
Claims processing, for those of you who don't know what MMIS is.
Thank you for helping me with that. That's what I get. But so we have learned a lot, but the costs are significant. And the most recent Medicaid plan selection implementation was not free. There was several $1 million that it cost for our vendor to implement that for us, again, with 90-10 match.
Other comments? What about Utah on that question? Any other thoughts or things you want to add?
So in Utah, we actually are what is referred to as an assessment state. So we have the federal government through the healthcare.gov, when someone applies through that process, if it appears as though the individual's income is low enough that they would be eligible for Medicaid, we get a referral from the federal exchange. We have a state exchange, but our state exchange is based around small employers. So it's just a small employer exchange. We didn't try to get in. We didn't want to, frankly, spend the money to build a state exchange, and we felt like this was, the federal government's issue, and they should do their part and just let us know when they think that person's eligible. The referral comes over, and our eligibility agency and our system then does the determination of eligibility for Medicaid. So we're in a different sort of arrangement than the state of Washington is. And we were, in fact, fortunate to already have an eligibility system that was built and up and running. So developing that interface with healthcare.gov was not as difficult as a lot of states have experienced. And I'm just going to inform Washington that the same contractor that built your MMIS is building Utah's MMIS, so we'll see how that goes.
Well, good.
Talking.
They've learned a lot, and we've learned a lot.
Good. We're hoping they learned a lot in Washington.
Always a mystery to state officials that the same vendor can have great success in one state and not so much in another. Never could figure out why that happens. Any other comments on the technology question or the investment question? Other questions from the audience? Yes, ma'am. Yeah, go ahead.
Thank you. I have a question about outreach, education, and awareness. There was some one-time money that was available, I think, to all the states that entered or used the Affordable Care Act dollars to engage people in the process of actually navigating the system and applying for the program and that kind of thing. Now that that's over, what about the process of educating people on how to best utilize the insurance and utilize the system, especially for those who've never been insured before? And then right now, we're engaged in the process of re-verifying income, which has become a total nightmare in Arkansas. And we're one of the, innovative states where even despite not utilizing those outreach dollars, we had over 250,000 people sign up for what we call the private option, which we know is still the Affordable Care Act. And many of those people are now, right now, being kicked off of it because they had 10 days to respond to a letter and then engage them in a 90-day appeals process.
I know there was money, there were pots of money that went to states that built their own marketplaces and different pots of money for states that didn't. So where are you guys at now with additional federal funds for that?
Sure. I'll have to get the state exchange folks up here to answer this question more fully, but I'll give it a shot. We did have a pretty successful Navigator program and successful outreach activities, and I, again, shared with you that our Medicaid expansion just blew the doors off of our expectations. A lot of that was because of a significant, mostly unpaid, community-based effort, but we did have the paid Navigator program, and it was really community-based organizations that were driving that and leading the work and did, frankly, across the state in every geography, a phenomenal job. What we also found with the Navigator program is the vast majority of people signing up through the Navigator program were eligible for Medicaid. And so that did create a different type of discussion as part of the budget process as to how to fund a Navigator program going forward and how to make sure it's focused appropriately on the right populations. And some of the legislators actually more involved in that discussion could better speak to it. But what I'll say is something new for our agency is we do have community outreach officers right now co-located in facilities, hospitals, clinics, and otherwise, helping people navigate the system, so to speak, that are not navigators and are funded through Medicaid administrative budget, and was an initial ask of the legislature early on in the implementation of ACA. And that program has proven very, very successful and something we are sustaining.
Great. Utah, any comment on that?
So we also had navigators in the community. When I say we, it wasn't Medicaid. They were funded through other resources, and it was essentially the same thing. United Way, our community health centers who actually administered the Navigator program to help individuals through the commercial marketplace. And again, as I've mentioned, we have staff within our Medicaid program who actually help individuals when they end up in the Medicaid or CHIP world. And on our eligibility side, our eligibility agency actually does have what we refer to as seated workers. So many of our hospitals and other community organizations have actually entered into agreements with our eligibility agency they pay the state share of that cost, and then we pull down Medicaid, TANF, food stamp, administrative funding to have individuals, again, like Washington, in hospital settings and other appropriate some even in the schools, actually, to help families through the eligibility process and to provide them with some of that additional assistance that they need.
Great. So our time, one more comment?
I just wanted to make a comment to our community health clinics. I received more postcards and more letters asking us to make sure we did Medicaid expansion and that we help all the Medicaid people. The outreach from the community health centers to the population was the most amazing outreach, and they continue to do that today, so I applaud their efforts on helping.
Great. So our time is up, but I do want to give the panelists if you want to say one more thing, advice to your colleagues in the audience about thinking about reforms and where to start, where to go next. Any final piece of advice?
I'd just like to thank all of you. I've enjoyed this conference and listening and learning from you. I've learned a lot, and to all my friends at CMS and HHS, I'd just like to say how much respect I have for you. And when we meet next week, I hope that we can work collaboratively.
Any other?
So I would like to say to those same friends, please come up with some guidance so that we can actually do these things. Come up with the rules so we know where we can go and how much we can work to break those rules. Without any direction at all, it's like a stabbing in the dark trying to hit the target, and our populations deserve to have the best that we can offer.
Thank you. Any other? Well, first of all, please, please, please fill out your evaluations and join me in thanking our fabulous panel.